Paul Werker is going to present in the stead of Sophie Riesmeijer. Polygenic risk scores predicts recurrence, severity, and retreatment for Dupuytren disease.
Thanks, Charlie, Dominic. Dear colleagues, I'm here to give this presentation on behalf of Sophie Riesmeijer, who unfortunately couldn't make it today. She will be here tomorrow. And she did a lot of work, as you already heard, about the genetic makeup of Dupuytrens. These are my disclosures. We all know that Dupuytren's has a very high genetic background, but we also know as surgeons that Dupuytren has a lot of recurrence after treatment. The problem is that it's very difficult to predict who will get a recurrence and who not. You've heard a lot about the GWASs already from the talk of Dominic, so I'm not going to talk too much about that. But just in summary, genome-wide association studies try to distinguish certain populations from the overall population, and that's what we have focused on. And if you take that genetic information, then you can use it to turn it into genetic risk scores. And there are two. You have the weight genetic risk score and you have the polygenetic risk score. And the difference between the two is that for the first, you only use the significant SNPs that have been come out, your GWAS studies, and for the polygenetic risk association studies, use all the information that came out of the GWASs. And Sophie has extensively looked into the value of these risk scores to predict recurrence, and she has published 2 papers about it. But in essence, these papers were only using retrospective data, and obviously we want to try and predict a recurrence. So she was striving to do more. So luckily, we started in 2006 a big database called the GODAF, which actually led to the first and the subsequent GWASs. And initially, we as doctors collected data, and the patients themselves filled out questionnaires. So we collected a lot of material. And on top of that, we drew blood from each of them, and that enabled us to get the DNA out and use it for the GWAS analysis. Now, we re-invited these patients back to our clinic a number of years later to take a look at their hands again and to maybe refine the diathesis features that we already collected before. And we measured their hands again, and we specifically looked for recurrences, of course. We excluded the patients who were treated by collagenase and radiotherapy because they were just very minor groups, minor subgroups. Now, recurrence was defined as retreatment of the same rate that had been treated before, and or as an increase of total passive extension facet of more than 30 degrees after treatment. We also looked for the time between the treatment and the outcome, for the treatment modality used, and then we calculated polygenic risk scores. Statistics, linear and logistic regressions, survival analysis. I'll show you a picture about that. And we looked at the receiver-operated characteristic curves. And obviously the primary outcome was the additive value of the polygenetic risk score to predict recurrence, time to recurrence, and the severity of recurrence on top of all the clinical characteristics. Now, we had 424 participants in the study. 3/4 of them were male with a mean age of 96. And more than half of them had a recurrence in between their first inclusion into the GODAF and the moment that we saw them. 181 were retreated, and 46 had an increase of total passive extension facet of more than 30 degrees without the necessity of an additional treatment. And we found that the time between the first and the second treatment on average was 3.8 years. And median time between the first treatment and the TPED increase measurement at the time of the visit was 4.3 years. And regarding the polygenic risk score, you can see that the polygenic risk score had an odds ratio of 1.5 in the prediction of recurrence based on the retreatment or an increase of TPED, so that's quite a lot. And if you take the polygenic risk score and you divide it in tertiles, so you distinguish the very high PRSs, the middle group, and the subgroup, then you get this complicated survival curve. And what you have to try and look for is for that red line, the green line, and the blue line. And the red line corresponding with the low PRSs, the green line corresponding with the median, and the blue line corresponding with the high PRS scores. And you can see that there's a clear difference between the three lines. The low PRS corresponds with a much better survival in terms of not getting recurrence than the blue line. And if you look at the area under the curve, you can see on the right that the addition of the polygenic risk score increased the area under the curve from 0.61 to 0.66, and that is also significant. So in conclusion, the polygenic risk score significantly improves the prediction of recurrence as well as the time to retreatment for Dupuytren's disease. The integration of the patient's genetic profile in a prediction model for recurrence of Dupuytren's disease adds to the predictive accuracy. However, this model needs to be further improved, and the health economic analysis needs to be evaluated before implementation into clinical practice will prove feasible. Thank you for your attention.
Questions?
Isn't the international consensus on recurrence 20 dB?
Sorry?
Is the international consensus on recurrence 20% or 20 dB,
Well,
and not 30, and how would this impact on your results?
yeah, we have always been different from that. Heinrich, thank you for the comment. We used the 30-degree mark for a whole ray as compared to the 20-degree mark for one joint that came out of all the collagenase studies and indeed from the Delphi study. Nonetheless, we still find the 30-degree mark for studies like this better because the 20-degree difference blurs the results. As you may have seen, the initial studies in collagenase suggested that the results of collagenase treatment were much better than the results of needle fasciotomy, but ultimately the difference evaporated when the same definition was used.
One more question.
You examined recurrence here. Is there any value in examining an extension of the disease as well?
Yeah, that's a very good question, but we decided to focus on recurrence because extension is an even worsely understood phenomenon. So we decided to stick to recurrence.
Great.
Okay.
Thank you very much.
Thank you, Paul.
Pleasure.